members who are here the long haul with us, and all the wonderful information that you provide on a monthly basis and in between on our Google groups. Unbelievable. I also want to thank our YouTube audience, of which has grown quite a bit, and just say that we appreciate you. If you like what you see, give us a thumbs up so we know for better planning for future content. And go ahead and subscribe, and then we really know you like what we're doing. Anyway, thank you. We're so excited tonight to have Dr. Kimberly Zambito, and I just want to tell you a little bit about Dr. Zambito. So excited to welcome her. She's a board-certified orthopedic surgeon. Her subspecialties in hand surgery, but in private practice, she has had a lot of experience, academic practice, multiple deployments to surgical teams with the United States Army Reserves. And these experiences have provided her with a no-nonsense approach. Her clinical interests include comprehensive hand and upper extremity care. She is a hand surgeon, and especially bone health is a specialty. She successfully developed a comprehensive bone health program for her previous practice, and she's received recognition as the first physician in the United States to introduce Echolight REMS technology to the United States. She's published research in peer-reviewed publications in hand and upper extremity, orthopedics and exercise, and sports sciences. She's been a guest speaker on podcasts hosted by bone health advocates, and frankly, we are thrilled to bring you here tonight, Dr. Zambito, and I'm just excited to welcome you.
Thank you for the really kind introduction, Shelley, and thank you for having me. I also want to thank Diane. We're really looking forward to coming to Boston or the Boston area in Western Massachusetts in the next couple months. So thank you again for having me.
Absolutely.
If you would like, I can get started with the talk that I have prepared for the Osteo Boston members. I would just need to share my screen, if that's okay.
Sure. Absolutely.
Okay. Let me get to the slideshow. It takes a moment, you know, you have to conquer the technology. Okay.
I understand that.
Yeah. Alrighty. So I've given this talk in a couple different venues. One was as a grand rounds presentation for the St. Luke's University Health Network, which is the network that I'm employed for, that I'm employed with. I do not do bone health for St. Luke's. This is something that is a passion of mine, and I do as a side job, the bone health. What I do for St. Luke's is hand surgery, as you mentioned previously. Let's get started. I find that a lot of people have some confusion with regard to what's out there in terms of evaluating bone health, and imaging is one part of the puzzle. So I'd like to focus this talk on imaging for bone health assessment and really focus in on DEXA versus R.E.M.S, because most of the questions that I receive have to do with DEXA versus R.E.M.S. So the goal is to develop a foundation of knowledge of imaging used for the evaluation and monitoring of bone health. The disclaimer, this presentation is not intended to be used as medical advice. The presentation does not establish a doctor-patient relationship, and I have no financial relationships with industry, meaning I am not paid by Echolight and I'm not employed by Echolight. Echolight is the company, R.E.M.S is the technology. I know you record this for YouTube. Oftentimes I don't have this recording distributed other than for the group. But if everybody has signed disclaimers in terms of consent to air this on YouTube, I'm okay with that. Imaging is an instrument to aid in the diagnosis and management of osteoporosis. You have to consider that you are an entire person, and imaging is one part of the puzzle. I always start my presentations with general knowledge about osteoporosis because everybody's at a different level in terms of their journey. So osteoporosis is a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration of the bone tissue, leading to enhanced bone fragility and consequent increased risk in fracture risk. This is defined by the National Institutes of Health and the National Bone Health and Osteoporosis Foundation, as well as the World Health Organization. Osteopenia is low bone mass or decreased calcification of bone without clinically increased risk of fracture. Osteopenia is not a diagnosis, it is a description. And now we're starting to see how that terminology is changing with regard to our DEXA reports because we're using the terminology low bone mass or low bone density rather than osteopenia. There are risk factors that you can control or manage, and there are risk factors that cannot be changed. And the risk factors that cannot be changed are your gender, your ethnicity, your genetics, and your body frame. Those that can be changed are your nutrition, your physical activity, the use of alcohol or tobacco, hormones, and medical conditions. I really think medical conditions can be divided into each group. Things that you can change and things that you cannot change. But more importantly, when it comes to medical conditions, you also have to consider the treatments for those medical conditions and how they may affect bone health. The workup can vary, so depending on who you are seeing for your bone health, people look at bone health from the lens of their subspecialty. So an endocrinologist may order certain tests, whereas an orthopedic surgeon may order something different. A rheumatologist may order something different, and a family practitioner, an OBGYN, may add some different tests. So people look at it in the lens of their expertise. But in general, we have a DEXA scan or another imaging study such as R.E.M.S, where I'll also go over CT scan, which can be used to evaluate and diagnose osteoporosis as well as use in monitoring for treatment. Serum calcium, vitamin D levels, TSH, parathyroid hormone, renal function, RBC magnesium, and other lab work is needed. Again, we all look at it in the frame of our expertise. And then we also shouldn't forget about the importance of a physical examination. So the presence of kyphosis or that extra curve or hyperkyphosis in the thoracic spine. We used to refer to it as the Dowager's hump. We can look at our timed up and go test. We can look at loss of height over time, and we can also look at sarcopenia, the loss of muscle mass over time. So there are different physical exam aspects that we can look at as well when it comes to the overall picture of evaluating somebody's bone health. Oftentimes, when I see people in the office as an orthopedic surgeon, I'm asked, can x-rays show bone loss? There's a technique called radiographic absorptiometry, which assesses the metacarpals and phalanges, so your hands, and then the computerized processing is applied to the x-rays to evaluate whether or not there's bone loss. It is an insensitive measure of bone loss, and abnormalities are seen after about 30% of bone loss. So this technique is not good for screening for osteoporosis as a diagnostic test or for monitoring bone health over time. DEXA is the most commonly used bone mineral density assessment tool. It is considered the gold standard, and it's done at central and peripheral sites, meaning it's done in the lumbar spine, the hip, and the distal aspect of the forearm. It does involve radiation exposure, although it is a very small amount of radiation exposure. So if you were to go out into the sun for the day or for the afternoon, you're getting more radiation exposure from the sun than you would from the DEXA exam. The technology of DEXA uses two distinct beams of X-ray photons. So there's a constant beam and a pulsed beam, and the amounts of the X-ray beam that pass through the bone and the soft tissue are compared to estimate the bone density. So it measures the sum of cortical and trabecular bones. So that's the hard outside exterior part of the bone, and then what people used to refer to as the spongy part of the bone or the inside of the bone. DEXA reports will vary from facility to facility. So when you ask for your DEXA report, you want to obtain the full DEXA report with the images. This is an example of the images that you might see on a DEXA report. Okay. This is critical in evaluating the quality of the DEXA report. Oftentimes, people come to us with just the report with the numbers, and we aren't able to really critically analyze whether or not the DEXA was performed properly and if the positioning was done properly. A minimum of 2 years is typically required to measure any changes in bone mineral density over time. And you have to be aware of the least significant change, meaning, is that change really a change in my bone mineral density over time? And in general, the rough rule of estimate is if it's greater than 5 or 6% change, that's a real change. If it's less than 5 to 6%, it is not a real change. Again, this least significant change should be reported on the DEXA report, as it is a calibration of precision of that instrument. However, not all reports have that on there. So as a rule of thumb, 5 to 6% change. If it's less than 5 to 6% change, it is not a significant change. If it's greater than that, it is a significant change. There are potential causes for error with the DEXA, and these are just a few of them. You always want to use the same facility and the same scanner because there are variations between scanners and variations between the facility. Positioning is important, so you want to make sure, or the technician should make sure, that you are appropriately positioned for your DEXA scan. The use of calcium supplementations within 24 hours prior to a DEXA should be avoided, as this can change the reading in terms of the way that calcium transits through your gut. You also want to be aware of the presence of implants or polymethyl methacrylate, which is cement used for kyphoplasty and vertebroplasties. And you also want to communicate to the technician if you have had a vertebral body fracture or know that you've had a vertebral body fracture and at what level. Again, there can be errors by the technician. There's also the concept of discordance. So sometimes the lumbar spine will say one value and the hips might say another value, and there can be a significant difference between the two areas, regions of interest. Okay, and let's not forget the failure of regular precision assessment, which has to do with the least significant change that can be a source of error. Oh, trying to get my slides to advance. I'm going to stop sharing for one moment and see if I can get the slide deck going again. Okay. Thank you for your patience. Okay. There's a software package called Trabecular Bone Score. It is a reflection of the bone quality, and it's derived from the analysis of the pixels of the DEXA image. It is more predictive of fracture risk than bone mineral density, clinical risk factors, and FRAX, which is the fracture assessment tool. It's done on the spine only, and it can be dependent on the image quality, edge detection, and whether or not there's a vertebral fracture, as well as the BMI. If you are interested in learning about TBS, Dr. DTA Hans is the head researcher in terms of the development of this technology. So I would recommend reading some of his work. Use of TBS in practice, the ISCD guidelines were issued in 2019 that TBS is associated with fracture risk in vertebrae, hip, and major osteoporotic fractures in postmenopausal women, and it's associated with hip and major osteoporotic fractures in men over the age of 50. It should not be used to determine treatment recommendations. It can be used to adjust FRAX probability of fracture. More on this in the next couple of slides. And the role of TBS in monitoring anti-resorptive therapy is unclear. And it can be potentially useful in the monitoring of anabolic therapy. On the right of the screen is an example of a report that you might find with TBS. there are a few parts to it. One is the TBS mapping. Two is the TBS spine results. Three is the fracture risk assessment, which combines BMD and the TBS score. And then therapeutic decision tools, which can aid in making decisions in terms of therapy based on your BMD and your TBS. And then the fracture risk assessment tool, I mentioned this when I was talking about TBS. If any of you have gone on there, it asks different questions with regard to your age, height, weight, previous fracture, a parent having a hip fracture. You can modify this and insert your bone mineral density for your femoral neck. And you can also, there's a modification which includes fracs adjusted for TBS. So the TBS can increase your risk for fracture. Information from that can increase your risk for fracture, or it can decrease your risk for fracture. So that tells us that bone quality does play a role in our fracture risk assessment. Quantitative CT, I just wanted to mention this. It can be used to evaluate the lumbar spine, hip, and other peripheral sites. It is the evaluation of the Hounsfield units, which correlate with BMD. So Hounsfield units are the gray scale that's seen on the CT scan. So this technique allows for the assessment of the cortical and the trabecular bone, and it can make volumetric BMD assessments, which is different than DEXA, which is an area. So DEXA is measured in grams per centimeter squared, whereas the quantitative CT can be measured in grams per centimeter cubed, so volumetric assessment. It can also be done as an opportunistic exam, provided that the place where you have the CT scan done has the ability or the software package to perform this. The downsides to this is the cost can be higher than a DEXA, and serial monitoring may not be practical, especially given the cumulative effect of radiation. CT scans do have a much higher radiation than a DEXA. It can potentially be time consuming, and of course, radiation exposure is higher than DEXA. If you are interested in learning more about QCT, Dr. Paul Anderson out of Wisconsin is a great resource if you wanted to look up his research. There are other forms of evaluating bone mineral density, which include non-ionizing imaging. I do want to mention MRI simply because it's used in the diagnosis of osteoporosis is evolving, and it's limited to centers which use MRI to evaluate osteoporosis as part of a research study. It is expensive, it is time-consuming, and it cannot be used for patients with metallic implants. Quantitative ultrasound is a screening tool. This may be something you have seen at a health fair. It evaluates peripheral sites, and the calcaneus is the primary site for the assessment. That is your heel bone. You can also do the tibia, which is your leg bone, the phalanges, which are your fingers, or the wrist. And it works off of the attenuation of the sound waves into the bone and the speed of sound, which correlates with bone mineral density. It's not reproducible, so it's not good for monitoring bone health over time, and it is less sensitive than DEXA, and in some cases may not even correlate with DEXA. So when we review all of these techniques that are available for looking at bone health, there are pros and cons to each of them. And I really started to look at R.E.M.S a few years ago. R.E.M.S is radiofrequency echographic multispectrometry. Echolight is the company name, and most people refer to this as the Echolight test, but it is R.E.M.S. It's an ultrasound technology which analyzes the echo or the pulses and mathematically processes the signals for comparison to the acquired spectra from diseased and healthy tissues. So what that is the ultrasound sends the wave to the bone, it reacts to the bone, bounces back, and then the computer analyzes those signals. And the way the team at Echolight developed this is they were able to look at people who had a history of fractures and people who did not have a history of fractures. And so that's how the analysis began in terms of looking at how these echo pulses and the related to BMD and then the fragility score. So it provides an estimation of BMD, which is called the osteoporosis score, and then it predicts fracture risk through the computation of the fragility score. So the advantages to this type of technology is there's no radiation, it's low cost, and it's portable, so you can achieve wider access for bone health care. It expands our ability to monitor bone health in special populations, such as during pregnancy. In the first 3 months of pregnancy, you can monitor the lumbar spine and the hips. After the during the second and third trimesters, you can only monitor the hips. You can use it to monitor a bone health in the presence of instrumentation. So for example, if you've had a spine fusion or scoliosis surgery, the presence of instrumentation is not going to interfere with the evaluation of the bone tissue, provided there's enough bone tissue there to analyze. It's not affected by patient positioning. As I mentioned previously with DEXA, patient positioning is important. And it's not affected by degenerative changes. I think this is an important concept, especially for people who have arthritis in their spine. Oftentimes the DEXA can give a falsely high BMD reading for DEXA, whereas Echolight REMS is not affected by those degenerative changes. And it can also this technology can exclude the cement artifact, provided that it's present. Okay. The meat of this technology, what really makes this technology shine, aside from the fact that it's an ultrasound and there's no radiation, is the fragility score. The fragility score is a dimensionless value from 0 to 100, and it's derived from comparison of patient spectrum to reference models obtained from patients with fractures and those without fractures, what I mentioned 2 slides ago. It's a reflection of the microarchitecture of the bone, and it is independent of bone mineral density. If you are interested in reading more about the predictive value of the fragility score, this is an article that I would recommend by Dr. Paola Pisani. I'll leave this on the screen for a moment, so if you're taking notes, you can jot it down. And here's that research article, just kind of summarized by Dr. Pisani, and it was published in 2023. They followed over 1,600 men and women for 5 years, evaluated the lumbar spine and the femoral neck, and then figured out, as they monitored them over 5 years, they recorded, did this person have fracture? Did this person not have fracture? And they found that the fragility score has superior predictive value for fracture compared to BMD from DEXA or BMD from R.E.M.S. And the lumbar spine value of 37.2 in the fragility score had a 9-fold higher risk of fracture. And in the hip, it was 31.9, had a 6-fold higher risk of fracture. So this research study tells us that the microarchitecture matters. And if you have not seen a R.E.M.S report before, this is page 3 of the R.E.M.S report, in which they combine the bone mineral density, or your T-score, with the fragility score and develop a risk classification. And then in this particular example, it's a risk of hip fracture per 1,000 subjects. So if you decide to get a R.E.M.S evaluation and you look at your report and you feel like, oh my God, my risk is so much higher on R.E.M.S than it is on DEXA, you have to keep in mind that the risk, the fracture risk on a R.E.M.S is per 1,000 subjects. So if we look at R3, which is highlighted here, it looks like 4 to 8%. That is not a percent, it's per 1,000. So if you must think about it in terms of percent, it's 0.4 to 0.8%. And this will make more sense to you if you choose to get a R.E.M.S evaluation and look at the report. This will make more sense to you. I do see that there are important future directions, especially with the potential of use of fragility score and monitoring treatment, as well as starting to monitor people at younger ages. Oftentimes I see women who they just don't know if they ever reach that quote unquote peak bone mineral density. I don't think it's fair to assess somebody who's very petite framed to somebody who is at the age of 30 and then make the assumption that the person that I'm imaging is ever reach peak bone mineral density. So I do think it's important to start monitoring at younger ages before we reach that menopause age or actually postmenopausal age frame. I think it also has potential with regard to preoperative planning and optimization of bone health prior to elective procedures such as total hips, total knees, cervical spine fusions, lumbar spine surgeries. And it may even have an opportunity to affect implant design in terms of matching the implant material to the bone density and the bone microarchitecture. So the take-home message for everybody here at Osteo Boston is that there are various imaging techniques for bone health, and there's pros and cons to each. You want to compare DEXA to DEXA and REMS to REMS over time. You want to compare, if you get a QCT, you want to compare that to subsequent QCTs. You don't want to mix and match and compare one to the other. It's very, most of the time people come to see me because they want to believe that their DEXA is wrong, or that you know they just want their DEXA to be wrong. And oftentimes it's not that the DEXA is wrong, it's that we just have to have another data point for people to make decisions with regard to their bone health. And REMS can give you that added data point or that added information so that you can make decisions that are best for you. You recognize that you are an individual and what works for one person may not work for another. And I encourage all of you to learn and grow and engage in optimizing your health, because nobody will care about your health the way that you can.
Mm.
Okay, so I want to thank Shelley and Diane for making it happen. That Dr. Bush and I, as well as the Better Bones team, will be in the Boston area from April 27th through 29. The cost of an Echolight REMS scan, if you want it, is $300. Shelley did forward the link. This is a link to my website, but the actual link to schedule the appointment, Shelley sent in an email. We do not have the ability to schedule from our offices. And then added to the, I wanted to also add the message that please do not call St. Luke's because I do not do REMS testing or bone health at St. Luke's. You would have to go to the website for either the website listed here or the website for Dr. Bush, which is Central Carolina Orthopedics. So I'm going to stop
Okay,
sharing my screen.
okay, and I'm gonna add myself. Wow, that was such a lot of great information. And I know that I'm sure we'll have questions, but um, I'm glad you were very specific about where to register, because I know we've had a lot of interest already. And I know, for one, just to tell you that after reading a lot about it from what I online and seeing you talk before on YouTube, I was very interested, and I selfishly wanted to bring you here for myself. So I'm kind of thrilled that we were able to get this going. I just think that the technology will add one more piece of information that will be helpful. So I know we have questions. I don't want to monopolize, but for now, I want to say that. And I also, I wanted to ask you just quickly, you mentioned, because I love to read about, we all do, we're kind of those people. But you mentioned the technology for, I don't even remember which one, I think it was TBS, was done by DTA Hans. You
Yes,
said
Dr. Hans.
Dr. Hans,
Mhm.
okay. And Is it HANS?
HANS. And he has some interviews that are out there on YouTube as well.
Okay. And that was right, that it was the TBS? Is that the,
Yes, he developed TBS.
okay. Oh, I did not
He
know.
and his team, I should say. It's always team effort, right?
Absolutely. And then when you talked about Dr. Paul Anderson,
Mhm.
uh, was that a study that was printed? Were those like something we could look up on PubMed or
You can look
um,
them up on PubMed. Some of them are open access, but Dr. Anderson, Dr. Paul Anderson, he's involved with ECHO, which is part of Own the Bone with the AOA. He is out of Wisconsin and he has done a lot of research with regard to bone health, especially with the application of QCT.
very
He's a great
interesting.
resource.
It's great. I did not know about that, and I'm really excited to learn more about that. Um, I'm going to open this up to the questions. I'm going to ask you from our chat some of the questions, if you don't mind, Dr. Zambito. Um, okay, the first one is, uh, does medication matter in the REMS test? For example, if one is on an anabolic drug like Prolia, will that affect the results?
So the whole purpose of those medications is to increase your bone mineral density. So depending on how long you have been on a medication, um, you would hope that you're going to see some sort of change. What's interesting is we don't know necessarily whether through TBS or through the R.E.M.S fragility score if changes in microarchitecture occur. And that's what's so exciting now is that we have these technologies which have potential to bring our ability to treat people better with regard to their bone health. So you can't so if this person is asking this because they've had a DEXA, a baseline DEXA, and they're getting a REMS, you cannot compare that DEXA to the REMS. You have to compare DEXA to DEXA, especially if you're on a medication. So you can't make that switch. You have to compare DEXA to DEXA and REMS to REMS.
That's very helpful because, I do think that I spoke with Irma Jennings, who is part of your, has done work with you in Pennsylvania. And she mentioned that her DEXA was completely different results than her REMS. And that it was very hopeful to her to see the difference, that the actual microarchitecture looked quite different.
Right. The big take home message, and Irma has talked about this very openly. So oftentimes people come with a preconceived knowledge or a preconceived idea of what they're going to see. And the common thing that I see is people look at their DEXA and they're not happy about their DEXA and they want to know that their DEXA is wrong. And so they come and get the REMS evaluation. And in some cases, it's the exact same thing. In other cases, the REMS confirms what the DEXA shows. And then there's other cases, whereas if you've got spine arthritis and you think that your spine BMD is going up, it's actually the arthritis that is causing an erroneous result. Because bone will respond by either making new bone or becoming just becoming destroyed or breaking down, right? And oftentimes with osteoarthritis, you're building more bone, so you're getting osteophyte formation, or you're getting, the bone is responding by making new bone. So it can make it look like your DEXA is improving over time.
Yeah,
And so that's the thing. That's why it's so important not to just look at one data point. You have to look at the whole person and the whole picture.
that makes a lot of sense. Um, and one thing I'm thinking about that is that the REMS is primarily done on the spine. Is that right? You're not doing it on the hips or the
No, the
femur?
REMS is done on the spine and the hips.
Oh, it is.
The TBS is only done on the spine.
Okay.
Yeah, and the TBS is a software package that is software package available for DEXA machines. So
Yeah.
not all DEXA machines have the TBS package. You have to specifically ask if a DEXA has TBS, and your doctor has to order DEXA with TBS if that is what you want. The REMS, we're looking at your spine, L1 through L4, and we're looking at the hips. And Dr. Bush and I image both hips.
Oh, excellent. That's not done in the DEXA. One of the questions you received, Dr. Zambito, is whether Echolight is going to Western Mass.
So are you asking if Dr. Bush and I are coming to Western Mass, or if you're asking if Echolight the company's
Oh,
coming?
no,
Right.
you
So
specifically, yeah.
yeah. So we are coming to Western Massachusetts. May 1st through 3rd is when we'll be doing some imaging studies there.
Yes, it's in
Mhm.
West Stockbridge at Crepallo.
Yeah,
Yeah,
near Kripalu.
it's great. Um, and just so everyone knows, when it's going to be in the greater Boston area, it will be at the Dedham Athletic Club in Dedham, Mass. Um, and ours will be on the 27th through the 29th. You'll be
Correct.
able to go in. I've already provided a link for you to go in and register. And tomorrow, I believe it will open up to all of the clients in the Better Bones community. So if you know you want a certain time, you might want, and you're convinced you'd like one, you might want to
Right.
do it today.
Right.
No pressure. I mean, it's just being honest. Okay. Will Echolight be in Chicago this year? Or, I guess from your perspective, will you be showing?
So we don't have plans to go to Chicago this year. We are in the talks of going back to St. Louis in the October timeframe.
Okay. And we heard that in that location, which was your first one, um, and thank you that we are your second,
Yeah.
that people flew in from everywhere. So
Yes, we had people come in as far as Alaska. Yeah.
amazing. Okay. Um, could you redefine for us QCT, since many of us weren't aware of that technology?
Yeah, it's quantitative CT, computed tomography. So like a CAT, people refer it as a CAT scan, but
Ah,
it's so what this is it's what we call an opportunistic exam, which means you've already had a CT scan of it, of like your spine, or you had a CT scan of your abdomen where we can look at your spine, but you have to have the software package with the capability of analyzing it.
okay,
Yeah.
because I just had a CT scan of my spine. So in other words, I would have needed them to added something to it to,
Yeah, you would have to ask. So wherever you had your CT scan, you can ask, do you have opportunistic CT scans to evaluate for bone mineral density?
okay, before you have it.
They might be able to apply it afterwards. I don't know a whole lot about that technology. It's not a technology that I use.
Thank you. And any thoughts on how we can get hospitals to offer the TBS? It's often not done in the Boston area and many other places where we're called Osteo Boston, but we're really from everywhere. So,
Yeah.
um,
So with regard to the TBS, you'd have to ask why the hospitals don't have it. I don't know if it's a cost. It could be that, there are some hospitals have it, if they just aren't advertising. I don't know about that area. I know in the area where I am in near the Philadelphia area, there are a few places that have the TBS, but similar to REMS, the word is getting out there. Previously, there was no CPT code for the TBS. There's now a CPT code. So I imagine as time goes by, it'll start to gain traction, but I don't know.
very accurate question. And then let's see, someone asked, let's see, um, what is the expected rollout? I don't know that you're not, Rika, I don't know that, oh, is there In other words, what would the timeline be that you could imagine yourself on having this technology, this REMS technology, permeate the medical community and it be accepted into, insurance programs and Medicare, et cetera, so that it would have greater access for all more people.
Right. So it's accepted in Europe, and in Italy, it is the method for evaluating BMD. It was it gained FDA approval here in the United States in late 2018, and then as they started getting traction, COVID hit. So I feel like that really played an impact with regard to here in the US, but you also have to consider the US market is very different. The healthcare setting is very different than what it is in Europe. And you have large entities that are involved. So I think it's going to gain traction at some point in time. I just think it's going to take time, and I don't have any estimate or any guesstimate that I can offer.
And it seems interesting, Dr. Zambito, that it wouldn't be more prevalent already in that it's small, portable, seems so accessible, in comparison to the large DEXA machines.
Mhm.
Um, I mean, I know they're providing different information, but I just think it's anyway. Let's see, someone else asked, as a DEXA, we're recommended every 2 years. How often do you recommend REMS is repeated?
Right. So REMS, I usually recommend once a year. Everybody's different with regard to what they want to do. Some people want to monitor their bone health at closer intervals. REMS is sensitive enough to track changes at the 6-month interval. I think that's a little overkill unless you're on an anabolic or some sort of medical treatment in which you really want to track those changes over time at shorter intervals. I do have some people who have done, since DEXA's every 2 years, unless you're on some sort of medical treatment, on the opposite year, instead of doing, when they can't do the DEXA, they do the REMS. So then they've got 2 data points that they can look at and track over time.
Okay, that's helpful. Thank you. Um, Someone asked, in terms of the DEXA, that they had taken calcium supplements prior to having the test administered. Um, is there an explanation that you could give of why that would
Right.
increase your score or a better reading for your score?
So you're measuring the mineralization in the bone, right? Bone mineral density. And when you are taking in calcium supplementation, they tell you prior to your DEXA, don't take calcium 24 hours ahead of time because there's a transit time between your mouth to the other end. And so if it's traveling, if there's some sort of calcium supplementation which is traveling within your gastrointestinal tract, it may be picked up. I honestly, I don't know how much it changes DEXA. It's just one of those instructions that most of the time we give people: don't take calcium supplementation 24 hours prior to the DEXA because it can lead to an erroneous reading, or it's probably at one particular vertebrae.
Good to know.
Mhm.
Good to know. Uh, in terms of how it's administered, the REMS test, could you prepare people for what will happen theoretically when they come to have one done?
Right. So you'll receive a video on how to prepare for your REMS evaluation once you sign up for it. But in general, I tell people there are basically 5 steps. You want to arrive on time. So I always tell people arrive 15 minutes ahead of time. So if you have to use the restroom, you can use the restroom. We run a tight schedule. So if somebody comes late, doesn't mean we're going to accommodate you, because we have to like move people forward, right? Um, So arrive on time, arrive ahead of time, 15 minutes ahead of time, use the bathroom, please. Before we call you back to the room, make sure you're wearing loose-fitting clothing. So what we have to gain access to is your abdomen from the bra line down to just past the belly button. So you want to make sure you have some loose-fitting clothing. I do not recommend jeans or anything with a belt, belt, snap, zippers, like elastic waistband stuff, stuff if you're going to go eat a big Italian meal afterwards, it'll accommodate. And then when we access, so for the lumbar spine scan, the lumbar spine scan is accessed from the abdomen. And the reason we do that is that vertebral bodies are located anteriorly. So we best access them through the abdomen. So the lumbar spine, each lumbar spine, the actual whole scan takes about 2 minutes, and then that data is acquired and analyzed, and that can take a few minutes for the artificial intelligence to really process that data. And then a report shows up on the screen, and you can take a quick look at the screen, and we'll show you what your BMD is, your T-score, and then the fragility score, and then we move on to the hips. So Dr. Bush and I image both hips, okay? Each hips takes about 2 minutes to evaluate, a little less than 2 minutes to evaluate. And the same process happens once that data is analyzed. After a few minutes, a report is generated. We can share your T-score as well as your fragility score. Excuse me. And then we save that information onto a USB drive for you, and you get to keep your USB drive with your 3 reports. And then afterwards, if you have any questions about that, you can schedule an appointment for an educational consultation with either me or Dr. Bush, which will be done virtually. We just are not able to accommodate that
That's
during our
all.
trip to Boston.
I,
I have done a video on understanding your REMS report. So I'm working on getting that set up on my website where people who have had the REMS report with me or REMS evaluation with me or Dr. Bush can access that. It's an educational video, and if after that you still don't understand your REMS report, then you can schedule the appointment. So
that's helpful. I also was told, that I don't know if this is true, that you could bring someone in with you, and while you're doing the scan, you'll be talking about it. And that it might be helpful to have someone take notes on what you're saying, since it's going to be a half an hour session for each person.
So the session
Oh,
itself is not half an hour. We built the half an hour into there because the actual REM scan takes about 15 to 20 minutes. And then we have to turn over the room, which means we have to clean the room, we have to reset the computer. So there's a lot of process that goes on behind the scenes that have nothing to do with talking to people. But the thing is, sometimes we have to redo a scan. So if somebody had, sometimes it's not a, hey, I scanned you, everything's beautiful, let's move on. Sometimes you have to scan a hip 5 or 6 times before we get a good value. It's rare, but it can occur. So we build in that time into these appointments so that if that happens, it's not a domino effect with regard to the time. If you want to bring somebody into the room, I don't know what the size of the rooms are. You're welcome to do so. I personally like to concentrate on what I'm doing and not instructing somebody about what I'm seeing on the screen. I don't mind a little bit of conversation about that, but my goal is to provide a good quality REMS evaluation for the person who is undergoing it. So it's your choice. It's it's up to you.
okay,
Yeah, but you'll have the report and everything right there on that USB drive, and it's all yours to keep.
okay,
The other thing I want to say, try not to eat 2 to 3 hours because sometimes we have to push on the abdomen with the transducer, and that can get a little uncomfortable, especially if you've eaten right beforehand.
okay. And also, do you use that same gel that you use when you have a regular ultrasound? It's that.
The ultrasound gel, yeah, it's the
Yeah,
same gel, so it brings back some memories for some people.
that's
Mhm.
right. Okay,
Also, before I forget, bring a yoga mat or a towel. We are trying to minimize medical waste, so we don't like using paper to cover the tables. We use
mm,
massage tables to do the REMS evaluations on. I just have people lay their own yoga mat. So you're laying on your own yoga mat or your own towel.
great. I like that. Okay, let's see. I think you just have a couple more questions, if you don't mind.
Mhm.
Um, since it's difficult to have access for us to this test, Do you think there's still a benefit to have it done now when we don't know if we could really get it done again soon, as you
So
suggested?
right. So it depends on what your terminology of, what your thoughts are in terms of soon. If you're looking to do it every other year, I'm located in Bucks County, Pennsylvania, which is about 4 hours away from Boston. Dr. Bush and I are planning to travel around to bring this technology. So if everything works out well with, various sites, then we can, establish those sites as key sites and try to plan those trips around those sites at the same time every year. So for example, with the St. Louis trip, we're planning to go back there in October because it was just such a great opportunity to bring the technology to people in that area.
Okay. And then, is the consultation that you talked about having in the event that the video doesn't supply enough information, will there be an additional cost for that?
So the consultation cost is $150 for half an hour. And I will reassure you that after watching the Understanding Your REMS report, I have had one person reach out to me not understanding.
Good
Okay,
to
and I've
know.
I've done a few hundred of these. So, yeah, so everybody wants something different, and oftentimes we do these consultations, I tell people, when you're with a physician, you have a limited amount of time with a physician, right? And so you want to make the most out of that time and come prepared with your questions and whatever information you can get. For example, in private practice, I had webinars that I did, and I instructed people listen to these webinars because they're going to answer all the questions that you're going to ask me. So when you spend half an hour with me, you can make the most value of that time. And that's how Dr. Bush and I both feel. We're going to be offering educational options on the website. It's a work in progress, um, but at some point in time, we want you to understand that the time that you have with us is valuable. We understand that it's valuable to you, and you understand that it's valuable to us. And we want you to have the most value coming out of that consultation with us in terms of, learning about your bone health and learning about REMS or DEXA or what have you. It's such precious time. It's such a precious relationship, and you want to walk away feeling like, I learned something from this, and I can make um, good decisions for myself.
Absolutely. Um, thank you. Let's see,
Welcome.
one or two more questions here. Um, do our docs and our endocrinologists, rheumatologists have enough information about this that these results will be helpful to them in treating us? In other words, can we bring our results with us and have them interpret them as well?
So I will say, since the technology is fairly new in the United States, your endocrinologist, your family practitioner, your OBGYN, they may not have awareness of this technology.
Mhm.
It may not be valuable to them, but I have had some physicians reach out saying, "Hey, I'm really curious about this. Can you tell me more about it?" Um, so as far as your personal doctor, I don't know, if they'll be open to it or if they won't. It's
Yes, well, good answer, because we don't know. Some of us have had great responses to the TBS score, and some have not, so I
right.
imagine that would be similar. Um, in someone with scoliosis, does the T-score on REMS tend to run higher or lower than the DEXA, or does it depend? And seems like DEXA isn't accurate in the spine of someone with scoliosis. Does with So let me ask that, and then the last question was about arthritis and REMS.
Right.
Okay.
So yeah, I'm seeing it on the chat. It's a great question. It's really a great question. So I'm not going to say the T-score is higher on REMS or lower on REMS when it comes to the T-score for scoliosis. The benefit to REMS is I have a transducer, and what I'll do is I'll image your spine and I'll figure out where your what your curve is, and then I can manipulate the transducer so it's over each vertebrae. And so I feel like I would say it's more accurate than a DEXA when it comes to scoliosis. Whether it's higher or lower in terms of your T-score, I don't know.
Excellent. And then the other question was, does REMS with arthritis tend to run more or less dense?
So mentioned previously, with osteoarthritis, bone will tend to react by making more bone and producing osteophytes, or what we call bone spurs, right? So that can make your bones look more dense. And so the DEX is not able to discern that. With REMS, it is able to discern that. REMS is able to eliminate by artificial intelligence the bone density related to the osteophyte formation. So oftentimes the DEXA T-score might be minus 1.3, but then when you get your REMS, it can be minus 2.1.
Yeah,
So it can be lower. So the DEXA can give you a falsely elevated BMD.
yeah. That's what I thought. You spoke about that a bit, and I think that's very interesting. I'm sure many of us have arthritis in our backs. Pretty common. This has been so educational and so helpful for all of us. And I just want to thank you so much, Dr. Zambito. I can't wait to meet you in person. And welcome to Boston early. We're already feeling like you're here.
Thank you. Thank you for having me. I really appreciate the opportunity, Shelley. And I know Osteo Boston is a labor love for you, and you can really feel the energy among the participants, and your group really cares about each other. So that's really special, to have that support when you're going through a diagnosis where people have been scared, and that's not necessary to be scared.
Yes, I
Hmm.
so agree with you.
Yeah.
Well, we appreciate you.
Thank
Can't
you.
wait to have you again.
Thank you. Thank
And
you.
oh, I forgot to say one more question is that the format of the program is April 27th to the 29th. In terms of what you'll be doing each day, is there going to be a lecture also, or will it be 3 days of scans?
So Dr. Bush and I have planned 3 days of scans, and it depends on how many fill up, how it fills up. So right now, the way the template is on the schedule, it's 9 to I think noon, and then once those fill up, then we open up more for the scans. I don't know if the Better Bones team is going to be giving lectures. Dr. Bush and I have not planned for any lectures, but if there's room for a lecture, I can certainly give the talk about understanding your REMS report for those people who have done it. Mhm,
Well, that would be great.
mhm.
I'd be right there in the front row. Uh, Um, okay, so the 27th, which I believe is a Sunday, you would,
I think it's a Saturday.
oh, is it? Oh,
Mhm.
yes, that's
Yeah.
right.
So
So,
we're so Saturday we'll be scanning in the afternoon, because Dr. Bush is driving from North Carolina and I'm driving from the Philly area. So we'll be up there in time to start doing some scans in the afternoon on the 27th. We'll do scans all day the 28th and the 29th as well. And then we move over to Western Massachusetts on May 1st to
okay,
start doing scans May 1st.
okay, so the 27th, it would be noon to 5,
Roughly, yeah.
and then the 28th would be 9 to 5,
Yes.
and then or 10 to 5, actually, I think, because they have the Dedham facility. I hope that's on the website, but they are not able to have it start at 9.
Okay, I'll
Yeah,
have to
better make
modify
sure.
that on my template.
Yeah, yikes, I didn't look at the link.
Yeah, yeah.
I hope that's correct, because I know the Dedham facility wasn't able to accommodate, they have something in there from 9 to 10 that
Okay.
morning. Um, and then the 29th, it would also be 10 to 5, or 9 to 5, that would be 9 to 5.
Yes.
Okay, well, boy, I hope that's right before people go in. Don't schedule it for, um, Sunday at 9 to 10.
Okay.
The false one in case it's up there,
Okay.
and if anybody can check. But
Okay.
anyway, well, Thank you again.
Oh, no,
You,
thank you for having me. Thank you and everybody for looking for the site to make this happen. I mean, that really speaks to the community that you have, Shelley. So thank you. Thank you for having us and thank you for having me tonight. I appreciate it.
it's a pleasure. And we have to thank Diane too for finding
Yes.
random analytical. Thank you, though. This was such precious information.
Thank you.